Good morning. My name is Carina Venter. I'm an allergy specialist dietitian from Denver, Colorado, where I also have a faculty position as Associate Professor of Pediatric Allergy and Immunology. The topic of my PhD was oral food challenges. I don't often get asked to present on oral food challenges, so I'd like to thank Dr. David Mendoza for the invitation to present to you today on this topic. I just want you to be aware of my disclosures. So the objectives of my talk today is to talk about the different types of oral food challenges, how to perform an oral food challenge, really the practical points, and then the difficulties of children that perhaps just do not want to eat during a food challenge and how to manage these situations. So food challenge, there's a general consensus that conducting an oral food challenge are the best method for diagnosing or refuting food allergies. If you want to know if somebody is allergic to a food and you have the slightest concern about it, the best thing is to feed them the food and see if they have a reaction. There are different types of oral food challenges. There are 3 different types. The first one is the open food challenge, where both the patient, adult or child, and the clinician know which food is being administered. So that's very simple. A child coming to eat a peanut cookie or a peanut butter sandwich, everybody knows the challenge is conducted with peanut. We also have the single blind challenges where the clinician knows that we're giving the child or adult egg or peanut to eat. That may be, for example, when we put liquidized egg in a fruit compote. And often these challenges are used because somebody is too anxious to eat the food or because they may have some subjective symptoms. So the child or adult is not aware that there's egg in the fruit smoothie or that there may be peanut in the cookie, but the doctor knows that the challenge is being conducted to the allergenic food. The double-blind placebo-controlled food challenges are very costly, they're very labor-intensive, but that's probably the best way of conducting food challenges. And this is often used in research purposes or when the subject has got subjective symptoms, which is difficult for the clinician to tell whether the child or adult is having symptoms, and also when the subject, the adult or child, is not really sure about whether they are having symptoms or not, or they may actually get symptoms just basically due to anxiety. That could be like tummy ache, having a headache, feeling tired. So these are called the double-blind placebo-controlled food challenges, and it's because both the doctor is blinded, so the doctor doesn't know whether the child or adult is eating the allergen, and then the individual, the child and adult, also doesn't know whether they're eating the allergen or not. And so this is typically conducted over 2 days. So the one day will contain the allergen or not, and then the second day, same situation. So this is an algorithm published by Anya Novak-Vexrain in 2009. And it looks like a very complex algorithm, but the bottom line of the algorithm really is to say that for clinical purposes, if we're dealing with objective symptoms, so a child or an adult with acute profuse vomiting, angioedema, and hives, we can do an open food challenge. And if the subject have difficult to interpret symptoms, like I've already said, tummy ache, a headache, or perhaps flaring of their eczema, then it may be better to do a blinded challenge where both the clinician or the child is blinded, or if it's purely just because the child or adult is anxious, we can do double-blind, a single-blind placebo-controlled food challenge. So I've put the reference there for you at the bottom to refer back to this algorithm. So now that we've talked about the different kinds of challenges, we need to talk about which challenge dose we should be using. And again, in 2009, Anya Novak-Vexrain published on behalf of the American Academy of Allergy the oral food challenge report, where they recommended that 10 grams of the dried food should be given over the course of the food challenge. Now, this is pretty easy in terms of peanut flour, where we give about 2 teaspoons of peanut. It can get more tricky when we use wet food like a peach, where a child may have to eat up to 3/4 of a peach over the course of the morning. The challenge is divided into about 9 or 10 dosages. In terms of wheat flour, we will start with about 10 milligrams of wheat flour, which is difficult to measure off, and then it actually exponentially increases until we end with a final dose of 2.44 gram, which gives you a total dose of 10 gram of the wheat flour. And so if this is your preference, which is still an acceptable way of challenging a child or adult, you can find these challenge protocols and also the different amounts for different foods to give in this oral food challenge report. For research purposes, the practical guidance was published in 2012 by Professor Hugh Sampson, where you can see now they don't recommend an amount of food like 10 gram of the dried food. They actually recommend a protein portion. And the practical guidance recommended 4.443 gram of protein. So whether that's a peanut or whether that comes from an egg or whether that comes from a peach, doesn't matter. We always aim for this amount of protein. And so again, if you can see in terms of peanut, 4.443 gram of protein, depending on the peanuts and the peanut flour you use, we talk about 3 to 4 grams of peanut flour or peanut butter, which again is still a reasonable portion for a child or an adult. But when we look about the amount of protein in a peach, the child or adult would need to eat about 5 to 6 peaches over the course of the morning. And by that point, most people will have tummy ache and diarrhea. So again, practical, very useful for the main allergens, very useful for research purposes, particularly into the main allergens, but less practical and feasible when we think about wet food. The practical dosages also start very small. It's about 3 milligram. For this, you will need a special scale. Most kitchen scales can't go down to that small amount. It again exponentially increases to the top dose, which is 3 gram or 3,000 milligram, to give, like I've already said, a total of 4.443 gram of total protein over the course of the challenge. And here you can see in this document, they do specify the amount of milk powder that will be needed, hen's egg that will be needed, or hen's egg powder that will be needed, and also how much cow's milk will be needed. So very useful to refer back to these papers to see how much should be given. We personally, and me personally, very rarely use the practical guidance for clinical challenges. We use that very often for research purposes, but it is very cumbersome to actually measure the food out to the very last decimal. And I can tell you that I've sometimes, if I've prepared the challenges and the challenge dosages before the day of the challenge, been measuring off till about 3 a.m. in the morning, because it's so hard to get these very, very complex challenge dosages, like I said, up to the very last decimal correct. And really, this should not be used for clinical challenges. And this is just a very busy grid where I'm just showing you if we use the practical dosages. For milk, we're going to give about 130 milliliters of milk, or that's about 4 to 5 fluid ounces of milk, if you prefer that. It's about 3/4 of an egg. It's about 13 peanuts. And there you can see in terms of hazelnuts, we'll have to give 22 hazelnuts. Still doable. Not a lot of tuna and prawn to eat. But in terms of parsnips, tomatoes, and apples, it's really huge dosages. So works very well for the main allergens at the top, but not very well for the foods that's got a lot of fluid. So it's not always that practical. But then following on from that, you know, we thought these guidance have been written now more than a decade ago, and we need to update the guidance. But we also had the problem with introducing peanut into early life, because as you know, most guidelines now recommend that peanuts should be given to infants from about 4 to 6 months of age. And if they have a positive skin prick test or specific IgE, we have to do a peanut challenge in hospital. So this is a document that I've been involved in, the conducting oral food challenges to peanut in an infant, with Andrew Bird as the first author, and there you will see my name as well. And these are very practical challenges. We worked with peanut butter, peanut flour, and then also the bamba or any kind of peanut puffs. And we did divide it into 5 dosages. We give measures in teaspoon. We do give measures in gram if you prefer the gram, And then we also give advice or guidance on how much fruit puree or vegetable puree you will need to mix with the peanut butter. So really very easy portions, 1/8 of a teaspoon, 1/4, 1/2, 1 teaspoon, and 1.5 teaspoon. And it's very easy to do these challenges with the little babies. You can also mix the peanut butter with hot water and cool it down. Again, very similar portion sizes as the previous slide. You can use peanut flour. Again, the portions look bigger because here we end with 2 teaspoons opposed to 1.5 teaspoons of peanut butter, but it's so easy to dissolve in pureed fruit or pureed vegetables that the actual portion and the volume that the child needs to eat is not really that much. Or you can use peanut puffs, like I said, like Bamba or any other peanut puffs if available in your country. And again, we give you the grams if you like grams, but you can just count the sticks as well to make it really, really practical. So following then on from the peanut challenges, the Quad AI developed a new update to the Oral Food Challenge report, which was published just last year. I almost want to say this year. I can't believe we're already in 2021, but it was published just last year, and I personally love this report. I'm not a co-author, but I think it is so practical when you want to do oral challenges in clinical practice. And so just to remind you, we've had the 2009 Oral Food Challenge report, which starts with very small dosages of about 10 milligram in about 9 to 10 dosages. Then we had the very complex practical guidance, and here I'm particularly showing you milk. And now we have the updated challenge report. And what this challenge report is saying is that the total dose or the total dose that we want to give to a 4 to 11-month-old infant, 1 to 3, 4 to 8, or 9 to 18-year-old is about 4 ounces of formula. If we look at milk, 4 to 8 ounces of milk, 4 to 8 ounces of milk, and when they get to 9, 8 ounces of milk. They also give a portion size for cottage cheese, for hard cheese, and for yogurt. And then they say, whatever dose you pick, let's say you pick a half a cup, or you may pick 1 ounce of hard cheese, you can then divide it into just 4 simple dosages with about a 12, a 6, a quarter of half of this total serving. Or if you're nervous that the child may react or the adult may react to the first dose, you can divide it into 6 dosages, which is 1%, 4, 10, 20, 30, and 35%. So really very practical. You know, you have a top dose, you divide it into 4 dosages, or you can divide it into 6 dosages if you're particularly concerned about giving a large top dose. And they've done that for all foods as well. So you can look in this report for dosages for egg, for peanut, for many, many different foods that the children may eat, as well as tree nuts. But then, you know, we have had the early introduction of peanut challenges. We talked about practical open food challenges with top dosages and new reports. And then the third thing we need to talk about is the baked milk challenges. And this lovely baked milk challenge recipe was published by Leonard et al. In 2015. It gives you about 1.3 grams of milk protein. The muffin needs to be baked for about 30 minutes. If it's a smaller muffin, if you can condense it, you can get away with baking it for about 15 minutes. I also, in children that may be more used to the texture and the flavor of corn products, I also use these recipes, and I use half a cup of the wheat flour and half of the recipe as wheat flour and half of the recipe as corn flour, because it does make a really nice corn muffin, which children may find more acceptable. It's important to bake it through. So like I said, a large muffin for 30 minutes, a small muffin for 15 minutes, because as you can see here, the soggy bit matters. And when we actually look at the allergen, so beta-lactoglobulin is destroyed during heating. That's our whole point. And when we bake it well, the amount of beta-lactoglobulin, which is the whey protein, is almost not present in this muffin. But when we actually don't bake it well, especially in the middle, then the BOS-D11, which is the casein protein, which is more difficult or almost impossible to be destroyed by heating. You will see that heating does reduce a bit of the casein, so on the outside, the baked bottom and top, but the soggy bit in the middle has still got a lot of casein, and so there is a risk of severe reactions if this muffin is not baked through. So very important for the challenge, and then for subsequently eating it at home, if they pass the challenge, to be very clear to families that for baked egg and baked milk, it has to be baked through. Then I'm also all sure you know about the milk ladder, and that we now have a shorter IMAP milk ladder with 6 steps, where we start with a cookie, then a muffin. This muffin has got a slightly less protein than the Mount Sinai muffin I've just showed you. So you can do 1 muffin and then perhaps 2. Step to a pancake, cheese, yogurt, and then pasteurized milk. And this is also another way of performing introduction of cow's milk if there is no IgE detectable in the child's bloodstream, or their skin prick test is negative if they have IgE food allergy. And if they have simple non-IgE food allergy, then of course the IMAP ladder is the preferred way of getting graded amounts of milk into their diet. For egg, again, you know, I'll just show you. We had the Anya Novak report with the 10 dosages, the complex dosages with Fractal, which you may only want to use for research. And then again, here we have the oral food challenge report with beautiful total dose using a French toast or a large egg, or using a hard-boiled egg, again with the division of the dosages into 4 or 6 different dosages. There's also a baked egg recipe that's been published by Leonard et al. And like I said, equivalent to what we say in terms of the cow's milk challenges, it's really important to bake these muffins through. 15 minutes for a small muffin, 30 minutes for a large muffin. And these have got slightly more egg protein in 2.2 gram, opposed to the milk protein, which is 1.3 gram in the baked milk challenge. So, you know, this is sort of like the technical bit. As a clinician, you decide, are you going to do an open, single blind or double blind challenge? Are you going to use the Anya Novak dosages from 2009, the Practal dosages, or are you going to go for the latest oral food challenge report? If it's a tiny baby, you can do the peanut challenges as I showed you. If it's an older child and the food may not be peanut, you can go for the latest oral food challenge report. You can decide, are you going to do baked milk challenges or baked egg muff challenges, where I've given you the recipe. And now on the day of the challenge, you may have some practical issues. So it's important when we challenge children and also adults, because there's many adults with fatty eating behavior, that we find out, will they eat the food? You know, it's impossible to do a prawn challenge or a salmon challenge in somebody with a complete aversion to the food. And if they tell you that they're not going to eat the food ever after the challenge, no point doing the challenge. But if it is a child or adult with some aversion towards the taste of milk or egg, but they do say that they'd love to eat some muffins, or they may want to eat some lasagna or a pasta dish, or even have some tortillas with the egg in, where you can't taste the egg, but the egg is present, then perhaps you want to do a single blind challenge. So find out, will they eat the food, and do you need to mix the food? It's so easy when an adult has a peanut challenge and they say, I used to love peanuts, I'll eat them by the handful. In that case, you don't have to think about mixing, but definitely worth asking, will they eat the foods? In fussy eaters, established before the challenge what they will eat, what you can mix it in. It's important to just go with the flow and realize this 3-hour challenge may take 6 hours. Sometimes you may have to mix it in with foods that you don't think is good. I have mixed in salmon in a family that eat a lot of fish, so they wanted to introduce salmon into the child's diet, and she would only eat peach yogurt on the day. So I've mixed some salmon in with peach yogurt. When is a reaction really a reaction? So it's important to be clear about subjective symptoms, that reluctance to eat and say, I've got a tummy ache and I feel sick just because they don't want to eat, shouldn't be considered as a positive challenge outcome. And then also psychological symptoms. There's written case reports of adults that would literally break up in hives just from the stress of having to eat something they think they may be allergic to. So really find out about all those factors. You will often end up mixing, particularly in kids, like find out their likes, food dislikes, if they have special dietary needs, like they're vegan, may have kosher or halal eating habits. If you're dealing with a vegan, you're going to need to have a soy or a coconut or a pea protein-based yogurt to mix the food with, because cow's milk won't work. Important to know which brand name they may like, because again, getting back to the yogurt or an ice cream example, moms would say to me, oh, they love yogurt, or you can mix it in with the ice cream. And then on the day, you have a yogurt that they don't like. So find out which brand name they prefer. You can ask parents to bring in foods to mix with that the child eats at home, like the child's special jelly or jello, a syrup that the child may like to put in. Cow's milk, we don't normally recommend syrups for children, but sometimes during the course of a challenge, that's the only way to get it in. We may want to think about tomato sauce to mix things in, but remember, if it touches the skin, it can cause sort of like contact rashes. So that's not my preferred thing to use during a food challenge. And sometimes, they may like a particular bread for sandwiches, or they may like a particular rice cakes, and that can be used. Rice cakes, so they can dip their hummus in the rice cakes and eat. Important, if the child have eczema, to put Vaseline around the face. And if you are going to allow the child to dip a food or feed themselves, always wash their hands carefully after every dose, because you don't want them to touch the skin and the chest and the legs, and the next minute you have hives all over the body. Because a contact reaction doesn't always mean an oral reaction. It's good to have things like blenders, microwaves, scales, freezers and fridges in a challenge unit to help you to store the food and prepare the food. And sometimes a play specialist, for children in particular, can be very helpful to just distract them from having the challenge, but still get them to eat the food. I talked about the feeding history, a list of foods that's already tolerated. You also need to think, are you going to ask families to bring in the food, or is the food prepared on the food challenge unit? We bake our muffins, but if we do, let's say, a fish challenge or perhaps a particular cookie challenge, we may ask the family to bring it in. I talked about the play therapist and the feeding therapist. If children have huge issues with textures, I often call the feeding therapist to help me to decide which format. Like, for example, if I do a beef challenge, is the child more likely to have cubes of beef or minced beef, or perhaps meatballs, or is, shall I fill like a tortilla with some meat, or shall I put meat in a potato cake? So that's quite often how the feeding therapist could help me. In the hospital kitchen, it's always good to have a yogurt and soy-based products, eggs to make scrambled egg or French toast, different kinds of wheat-containing things, gluten-free breads if they're wheat allergic, peanut butter, oatmeal, baby rice, always really good things to mix food with. On our challenge unit, we may have the muffins, we have some all kinds of tree nut and peanut butters and tahini paste and egg powder. And then, like I said, certain foods we do ask the families to bring in, just because the hospital kitchen cannot prepare it, and we most definitely can't keep it in the food challenge unit. Helper food as well, I've already mentioned about the fact that we can ask families to bring in helper foods, but we also have helper foods on the challenge unit, such as ketchup and mustard, which I already said is not my favorites, syrups, some jelly, chocolate syrup. If you get to the end of the challenge and all you need to get is that last dose of milk in, or soy milk in, or then perhaps chocolate syrup can just help you to get through it. But again, not something we would recommend for long term. Apple puree or sauces, yogurts, rice puddings. In England, where they eat rice puddings, I've used that a lot to mix my challenge food with. Corn puddings, oatmeal, corn porridge, for example. Mashed potatoes, very handy to mix things in. Fruit smoothies, I've made a lot of fruit smoothies in my life to mix milk or soy or pea milk with, if we think perhaps they may be pea or soy milk allergic. Soups can be handy, and then ground meat. Sometimes just mixing ground meat with ground fish and then make like a meatball with that can help to get the children to eat the fish if they're really struggling with fish during a challenge. And then always remember, this is my very last slide, that at the end of the challenge, we can't just say, okay, goodbye now. If it was a negative challenge, we need to talk about regular intake of the challenge food, ways that the child may eat the challenge at home and keep the diet consistently. But we really want to make sure that the child continues to eat the challenge food. That may mean that mom would need some specific cooking or baking instructions. And then, of course, if the challenge was positive, we need to just re-emphasize the importance of avoidance of the challenge food, and we need to make plans for follow-up visits and assessments. Sometimes nowadays, when our children have positive challenges, we may go on to start performing oral immunotherapy, but that is a talk for another day. So this is really my talk. I would like to thank you for your time, and I hope you found it informative. Thank you.